So much, Cameron, and thank you everyone for being here today for the National Alzheimer's and Dementia Resource Center webinar series. Today, our webinar is Community-Based Early Dementia Screening Leads to Support for Caregivers and People Living with Dementia. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. At this time, I'll turn it over to Erin Long from the Administration for Community Living for a brief welcome.
Hi, everybody. Thank you so much for taking time out of your busy schedules to join us for this webinar today. The topic is super important, and we are excited to have Winnie Lam from the Chinese American Service League and Halania from OMID to tell us about their experiences in working with to get screenings in the community. With that, I'll give it back to you, Sari, so we can start with the important conversation.
Great. Thank you so much. So as you heard, today's presenters are Winnie Lam and Halania. Winnie Lam has been part of the Chinese American Service League's mission to catalyze the transformation of individuals, families, and the community for an equitable future for over a decade. She works in a variety of home and community-based service positions within the organization and has been providing evidence-based mental and behavioral health interventions to all populations within CASL. Previously, Ms. Lam served as manager of Castle Senior Services and oversaw adult day services, the Alzheimer's program in-home services, Pine Tree Senior Council, and other senior service projects. As a licensed clinical social worker informed by her own immigrant experience, Ms. Lam is passionate about working with underserved populations, at-risk populations, and minorities to see how intersectionality has affected their experiences and to help them value and leverage their own strengths and resilience to reconnect with the community. Halania is also with us today. She currently is a program director at OMID for the Administration for Community Living's Alzheimer's Disease Programs Initiative Project. Ms. Nia has volunteered and worked with OMID since 2014. In addition to her work with OMID, Ms. Nia is an adjunct professor at the Fullerton and Orange Coast Community Colleges in Orange County, California. She is also a certified mental health educator, certified life coach, and yoga instructor. In addition, Ms. Nia volunteers with recovering addicts at rehabilitation centers in Orange County. At this time, I'll turn the presentation over to Winnie Lam to begin. Winnie?
Thank you so much, Sari, for the nice introduction. So it is very honored today to talk about the Alzheimer's project that we did in our agency, Chinese American Service League. We usually go by CASL. Kind of like some background about our agency. Our agency is a all-inclusive not-for-profit organization with 45 years of experience, connecting families and individuals with the vital support they need, providing an educational and cultural foundation to the children, ensuring our seniors live full and independent lives with dignity, enhancing education and training for tomorrow's workforce, putting immigrants on the pathway to citizenship, securing our community housing and financial well-being, navigating healthcare system and wellness resources, and fighting for equal access to justice. Since our founding, CASL has been rooted in the principles of equity and justice. That legacy continues to shape our efforts today as we strive to champion diversity, equity, inclusion, and accessibility at all levels of the organization. We are based in Chicago, state of Illinois. Next slide, please. Thank you. So today I wanted to talk about our work. This is the agenda. As you probably know, there are lots of problems encountered in the limited English-speaking communities. So those include stigma, lack of knowledge and awareness, lack of culturally and linguistically competent connections. Number 3, difficulty finding right or appropriate resources for the dementia detection and support. And finally, clients having limited time to communicate concerns to their primary care physicians, the PCP. So again, Council is a very traditional social service agency, even though we have 26 plus direct service programs serving 0 to 999, but we are just a social service agency. So as a social service agency, how we can do the groundwork in terms of dementia detection? Next slide, please. Okay, so as I said, this is kind of like the existing concerns that we have. So lack of knowledge and awareness. In our community, we have so many immigrants. They are Chinese, Asian, limited English speaking immigrants. And because of the cultural influences and because of the lack of knowledge, they have a lot of stigma. So in Chinese, sometimes they call dementia as craziness or madness. So you can see how stigmatized Alzheimer's and dementia is in our community. And also because of the education level and because of informed by the cultural background, they don't really have a lot of appropriate knowledge, professional knowledge about Alzheimer's and dementia. Second, yet there are a number of Chinese speaking clinicians, but they are doing primary health. For instance, medical providers providing primary health to the immigrants, to the limited English speaking population, but there is a very limited culturally and linguistically competent clinicians doing the dementia detection, not mentioning about the mental health in general. Thirdly, in council, we have about a number of senior service, direct service programs, like adult day services and in-home services. But as we have been doing those services to our clients, to our families, we also found it so difficult to find appropriate resources to link our clients up with the dementia detection and support services. And finally, as I shared before, our primary care physicians, they have very limited time to communicate with the patients. So those are the big four problems in our community. Next slide. So there are some solutions that we propose to tackle problem one, stigma and lack of knowledge and awareness on ADLD. So internally, we have been doing staff training. We trained 60 direct service staff to become certified dementia training. We used the training protocol developed by the National Council on Certified Dementia Practitioner to do the in-house training in their most familiar language, Chinese, and to assist them with the certification path. We also select 6 very important leaders to become certified Alzheimer's disease and dementia care trainer so that they can provide more direct supervision to the direct care staff, how to provide more dementia capable services and support to the clients in the home environment, for instance, through the in-home service support or through the adult daycare. For the rest of the staff members, in council, we have about 460 geriatric staff members providing direct services to the seniors. So for all other general staff, we host quarterly staff training. We cover a wide range of topics. At the beginning, we talked about introduction to ADLD, Alzheimer's dementia and related disorder. What are the 10 warning signs? What are the kind of like the common barriers that clients living with ADLD may have and how to tackle the challenges. And then later on, we talked about more advanced topics like communication skills, how to work with the caregivers, how to work with or roll with resistance when you provide services to clients living with Alzheimer's, dementia, and related disorder. Per our pre and post result, our staff indicated that they have knowledge gain in terms of Alzheimer's and dementia. most important of all, they feel like they have higher sense of competency in providing dementia-capable services to the clients. We are not just doing staff training internally to reduce the internal staff stigma in terms of doing the dementia capable services. We also help with the community, because if the community continue to have stigma, they are not willing to reach out for services. That's why we do monthly workshops at the community level in Chinese, in Spanish, and in English to talk about Alzheimer's and dementia. With proper knowledge, their stigma reduced. As one of the outcomes indicated, again, per pre and post survey, is a slight increase in terms of dementia attitude, positivity, and also they indicated that they generally gain knowledge about ADLD, Alzheimer's dementia related disorder treatment, and how to take care for someone with dementia, and how to advocate for themselves to get resources or connect to the services. We also do a lot of outreach because we have to kind of like broadcast, let me use this word, to other local providers. Yet now, finally, we have a linguistic and culturally competent services in the community. That's why we do a lot of outreach. Next slide. Problem 2 is the lack of culturally and linguistically competent clinicians. So our proposed solutions is we do all geriatric staff training and involve them in simple screening. As I share a little bit, we have around 460 plus direct care staff. And then we have about 800 clients receiving home and community services through council. There is no way that only a few clinicians can go to each of the clients' home to do the dementia screening. So our proposed way is to train our direct care staff to do a very simple screening, the Mini-Cog. And then they will activate this screening with the clients with client consent, and then enter the result into the customer relation management platform. And then when the threshold is triggered, we will automatically receive a referral. And then the Alzheimer's program team, who has a field clinician and who are trained and certified to do more comprehensive screening like MoCA, Montreal Cognitive Assessment tool, and other behavioral health assessment, they will be the ones to reach out to the clients to kind of like communicate our concerns. Hey, your Mini-Cog results indicated that you may have some cognitive impairment concerns. So that's why we reach out to you to kind of like understand what concerns or what needs that you may have, and whether you are interested in doing more comprehensive screening with our certified clinician, and then to see whether they really have cognitive impairments before we send the referral out to the primary care physicians or to the specialty. Next slide. The reason why we choose Mini-Cog is, again, it's a very simple screening questionnaire. It's 2 questions. It can be done in 3 minutes. It can be in person. It has to be in person, by the way, because it involves drawing of the clock. That's why it has to be in-person visits. During pandemic time, when we launched this project, is actually in the pandemic time. So some of the staff members have difficulty to go to the client's home to do the in-person visit to do the dementia screening. That's why we are having the certified clinician to administer blind MoCA, blind test of Montreal Cognitive Assessment, kind of like through telephone, and then to do the screening with the rest of the clients who have not been seeing our direct care staff during the pandemic time. That MoCA is kind of like 10 minutes. It can be on-site, it can be remote. Again, if you wanted to use the tool, you have to check out the website regarding the requirements and regarding the certification. Next slide. This is our internal process for your references only. Again, it's very tailor-made to our organization Castle. So in-house, as Sari said, we have adult services and in-home services. In the 2 years time, we have completed MoCA screening with 589 clients out of the 800. The reason why the rest of the clients are not completing screening, because again, we cherish all clients' self-determination. So if the clients refuse, we won't force them to do the screening with us because their collaboration is very important. And then out of the 589 clients who completed MoCA, 142 of them agreed to be referred to the Behavioral Health and Clinical Services Department. This is the department where I'm responsible for. And then they will do further assessment like MoCA, whether it's blind test or in-person test. And then our clinician will also administer other behavioral assessment to rule out the possibility that is other behavioral health stress affecting the cognitive impairment or the cognitive impairment symptoms. And then after that, with the consent, we will provide services based on their needs, based on their assessment result. Some of the clients see me said that, oh, I just need case management. Oh, yes, you are right. Thank you so much for administering the comprehensive screening on me. Oh, yes, I also agree that I have some memory issue. I have some sort of cognitive impairment symptoms, but I don't know how to seek for further evaluation. Please help me with it. Then with those kind of consent, we will link them up to the specialty or the primary care physicians that we have connection with to start the external referral process. Again, as you know, the US healthcare system is very complicated. That's why it's not like, simple one-to-one referral. It actually involves multiple back and forth case management services. And then we also provide counseling if needed. And then we will also provide other behavioral health interventions to the clients if needed as well, and if they consent. Next slide, please. So problem number 3 is clients having difficulty in finding the right or appropriate services for dementia detection and support. So again, we are not requiring them to fully enroll in our Alzheimer's program before we share resources to them. Because sometimes clients just wanted to, hey, I have those kind of questions, very ad hoc or very emergent, but I don't have time to come in for full assessment or to sign all the consent form and provide my personal information. I just want a quick inquiry or a quick answer to my inquiry. Then we will provide brief consultation. Again, we will try our very best to meet the needs of the clients even before their full enrollments in our Alzheimer's program. After their enrollment, we will provide case management to share resources, to share education with them. And if needed, we will link them up with the third party, kind of like other specialty or other healthcare professionals. And also, if needed, if clients consent, we will actually work with another party to provide coordinated care coordination to the clients and also the families. We also leverage the existing council programs to provide the support and services to the clients living with Alzheimer's dementia. For instance, link them up with the adult care, link them up with the in-home services, link them up with the like the housing program, because some of the clients may say, oh, yes, I have more questions related to the housing options that are available in the city of Chicago. Or sometimes we will link them up to the legal service team who may be willing to provide, for instance, advanced care planning, or kind of like 5 wishes to the clients and also the families. So those are kind of like how we utilize the existing programs internally and leverage the existing and new partnership to provide services to the clients and to solve this kind of problem a little bit. Next slide. Lastly, clients have limited time to communicate their concerns with the primary care physicians. We all have those kind of experience. Oh yes, waiting in the exam room, and then different people coming in to do different procedures on us, and then we only have very limited time to talk with our primary care physicians. So sometimes because we have limited time and sometimes because we have under stress, we may forget, oh yes, I forget to ask those kind of questions. So to prepare our clients and prepare our caregivers to remember to ask questions related to the cognitive impairment symptoms, we help them to prepare the referral report. On the referral report, there will be kind of like some findings, what we discovered through the comprehensive assessment, with the clients. Some of the partnership, we have memorandum of understanding. Some of the partnership, we don't have it because some of the primary care physicians said that, oh, we just wanted to work with you. If we wanted to go through the MOU, it'll be kind of like a very complicated process because we, kind of like a big entity. So that's why some of the partnership, we don't have an MOU at all, but they trust us, we trust them. We kind of like form informal partnership to help with the care coordination. So as I said, the referral report, how it looks like. Next slide. It's kind of like this. So kind of like, give some background information to the clients and also to the primary care physicians or to the specialty, like the specialty providers, what assessment we have administered on the clients, what are kind of like the findings that we have. And this will helpfully trigger their continued conversation, whether they need more comprehensive MCI evaluation, mild cognitive impairments evaluation, or dementia detection. Next slide. So this is kind of like the services we provide: case management, counseling, and also OT. If you wanted to have more information, please feel free to send an email to us. Last slide. Program sustainability. So as this is kind of like a grant funded project to help us to establish the program, but we continue to seek for private foundations and government funding to sustain the program while we are building up our clinical building capability. It's kind of like a long process for us. It can be another webinar, how we become Medicare accredited clinic, how we become the state of Illinois accredited behavioral health clinic. But again, we are still at the baby steps. We are not building yet. So that's why we are seeking out actively for private foundations and government funding before we can fully build for the clinical services. So last slide will be my information. Again, thank you so much for NADRC and also ACL for hosting this webinar. And hopefully there will be more linguistically and competent and culturally competent dementia support and dementia detection services across the whole country. So without further ado, I will pass it to the next presenter. Thank you so much.
Good day, everyone. Thank you, Winnie. What a wonderful presentation. My name is Hale, and I am the Program Director at OMID Multicultural Institute in Irvine, California. And we are a community-based early dementia screening agency that leads to support for caregivers and people living with dementia. Welcome everyone, and I hope to give you a brief presentation as to how we accomplished all the work that we have done so far, and perhaps you can utilize some of the experiences that we have had in order to move forward with your own agencies. Next slide, please. So OMID has been around for the past 12 years, and we have provided the marginalized communities in Orange County different services. We have provided them with educational classes, mental health services, as well as social service linkages. We have established ourselves in a committed way with the community, and we hope to be around for a long time. And we're hoping to become in the next year or so, perhaps a clinic, so that we can sustain our services to the community, especially the marginalized communities in Orange County. And so far we have been very successful, and we hope to move forward. Thank you. Next slide, please. So OMID is a highly regarded mental health service provider, especially for the Farsi-speaking community in Orange County, as well as other languages. We provide services to the Korean communities, the Chinese communities, as well as Hindi and Arabic communities. And we also are servicing the senior community and have been servicing them for the last 12 years. We have been working with adults, senior adults, for the past specifically 10 years through our early intervention programs, and we have case managers who provide these services in Farsi. Though not limited to dementia specific areas, and we have only started to work with our early dementia program, ICL, for the past 2 years. Next slide, please. So today I'll be talking about the steps that are taken through outreach process, in which community members with early memory loss can be identified through cognitive screenings as potential participants in dementia care and support programs. We also will discuss the role of stigma of mental health that can have the role that it plays in seeking and providing health among the minority group members in their caregivers and their caregivers on dementia care coordination. I will also cover the problems that we have encountered and potential solutions in seeking the limited English-speaking communities and reaching out to them for dementia detection, intervention, and support. We also are going to discuss how traditional social service not-for-profit agencies can use existing resources and expand partnerships to assist with dementia detection at the community level. Last but not least, I will also cover the pathway to dementia diagnosis for diverse communities. We are a first pilot project in the country for Farsi speakers, and we have been very successful at launching this program for many reasons. But I would like to take pride in saying that we have had a great team of case managers and other professionals who we have been able to work with in this program, and have been able to provide many services to these participants who are dealing with early memory loss. But not only that, I'd like to place emphasis of the importance of the role that caregivers play, and how we as case managers, our case managers, have been able to take the burden off of their shoulders throughout the program, and I will discuss that further down the line. We launched a program with training all of our staff and our case managers. We had many brainstorming sessions as to how to connect with the community, which is very, very important because of the stigma that is attached to mental health and the discussion on Alzheimer, dementia. We consulted with Alzheimer OC in Orange County, which has been a great help in assisting us because they have been working in the area for a long time, and their knowledge and their assistance was vital to our program and the effectiveness of the program. We had daily staff meetings. We adapted and translated all our materials into Farsi. We had we were diligently working on these translations for months, maybe even over a year. We covered materials such as all the screening tools, the care planning tools, consent forms, flyers, brochures, all the PowerPoints that were used in the classes, and anything that was basically needed to run the program, we had translated. And especially with making sure that we adapt everything culturally to the Farsi speaking community, especially the Persian community, in which that the culture was a very relevant phenomenon in playing this game of bringing these clients in, making sure that they understand that we're looking out for their interests and so on. Next slide, please. So building trust is key in the community, and because we have been around for 12 years, we were able to provide services, and they have been providing services to the senior community for over 10 years. We were able to connect and establish trust easily because we had already established credibility with the community through those other services. We also were able to and successfully able to work with case managers who were Farsi speakers. And we also brought in Spanish speaking case managers, as well as Arabic speaking case managers. So we were very lucky in that area because language plays a huge role in connecting with the community and building trust with the community. And we found that to be essential. We also provided one-on-one consulting services. We made our clients feel very special. We provided at least a 45-minute session for each client, sort of going over the program, all the services we can provide, even ahead of the game when we, before even we had them in as clients. We were very attentive to their needs. We continuously work with them in making sure that we establish a healthy relationship with them, as well as their caregivers, and listen to them very carefully. We actually had some training sessions for our case managers to become better listeners in order for them to make sure that they're attentive to the needs of our participants. And this is really important. I want to place emphasis on this, that we really didn't want to use the language of stigma or, Alzheimer or dementia. Why? Because there's so much stigma attached to these terms that we sort of try to avoid it because we wanted to just basically reach out to the community, bring them in, and if there was the interest, to invite them into the program, and if they were meeting the needs, to become part of the program. We had a lot of social events at parks, at community centers. We provided also classes at our OMID offices, as well as the senior centers all around Orange County. And we sort of spread ourselves all over the place to be able to reach out to as many Farsi speakers, Arabic speakers, as well as Spanish-speaking members of the community. Next slide, please. So we took a variety of different approaches to connect with the community members. We sponsored events through different collaboratives where we had a couple of different huge health expos inviting in the community, and sort of collaborated with either other agencies to bring in different community members into these spaces where people felt comfortable, and we provided at these events food and education and speakers, invited doctors and physicians as well as mental health providers to talk about different topics, sort of bringing the community members in. We reached out to adult homes, adult health daycare centers. We reached out to providers, family health, primary care providers, because they were essential to the program, because they're the ones who were initially exposed to their patients who were dealing with early memory loss. And we wanted to make that connection with them to basically, again, lift the weight off of their shoulder so that they can refer their patients to us as a sort of a stepping stone to see testing them for early memory loss. We also outreach to adult living communities throughout Orange County, and also family health daycare centers that specifically targeted particular Farsi-speaking community members, senior community members. We also reached out to different multicultural organizations that provided services to Arabic, Spanish, and Farsi speakers. And there was no, sky was the limit. We just went out there and did as much outreach as we possibly could. Next slide, please. Again, this is a important aspect of our outreach. We connected with community members through different media platforms. And sort of invited everyone into the program. We didn't just target specific seniors. We wanted everyone to feel that they were welcomed, so that we could basically not attach the idea of Alzheimer and dementia as a stigmatizing term to only the senior community. So we promoted our programs, our classes, and part of it sort of fitting in the brain health classes or dementia care program to the community through radio programs that were provided to us as a nonprofit, as 30-second advertisements we put out there. We also were connected to television programs through satellite, through that targeted the Farsi speaking community. Luckily, we have case managers who are also licensed psychologists and authors of different articles, and we had them published in various ethnic magazines and other social media platforms as well. We have our clients and community members sign up through our social media platforms, through Instagram, through Telegram, through WhatsApp, through Facebook. And we've been very, very active in the social media platforms, and they have been very, very effective, targeting specific community members in based on their ethnic backgrounds. Please, next slide, please. So we found that the key to bringing in individuals who are dealing with early memory loss was through education, not limiting those classes and educational trainings or programs to any age group. We invited all community members, even though we did have the majority of our classes at senior homes or daycare centers or community living centers that were mostly seniors, but we invited everybody in. And that was the key. We tried to embrace the idea of brain health and the importance of it and to the community, so that they understood that self-care is an important aspect of, especially when you are becoming older, And as you add on years to your life, it's important to not just physically take care of yourself, but also the brain and how the brain functions, and sort of bringing in everybody in through our brain health classes, our dementia friends classes, as well as caregiver classes. Again, not limiting it to anyone. We were very open to having all these different classes at these different centers, and we helped them both in person as well as Zoom. And we taught all our seniors how to use technology and come onto Zoom. We had case managers reaching out to community members, setting up technology classes so we could teach them how to connect to Zoom classes. Next slide, please. So the pathway to identifying early memory loss, we found it to be through the Montreal Cognitive Assessment testing, the MoCA test. We had our case managers trained and certified in administering the MoCA. We made sure that they were all of our case managers, whether they were Spanish speakers, Farsi speakers, as well as Arabic speakers, to become certified in the MoCA. We did the MoCA testing for the Farsi-speaking community in Farsi, Spanish-speaking community in Spanish, and the Arabic-speaking community. We found that most of them did speak English fluently and they were comfortable, so we administered those in English. After the screenings were conducted, and we would make the client feel very comfortable. We would have them come in either to our OMID offices, or we would go to their home to do the testing, or any convenient location for them. As long as there was a quiet space and we could reserve the space for 45 minutes to an hour, we would conduct the screening. And the way things were determined were if the client scored 26 or below, which indicated further investigation and follow-up, we would discuss it with the client at the time and ask them if they would be interested in joining the program, and so that we would sort of review the services we would be able to provide for them, and that we will be helping them and connecting them to their primary health care provider. And we had created a number of different statements and letters to connect with the primary health care providers for them to pursue more testing with their patients. Next slide, please. So we offer different services through our care program. We provide case management, which basically includes home visits, weekly home visits to the client's home. We also provide, we review their needs and see what kind of social services they're in need of, whether it's food stamps, whether it's transportation, providing them, a family doctor, any of those kinds of needs that they had. We also promoted our educational classes, and education, as I said, was key to bringing community members in, but also those who did score low or needed more care and more investigation. We, at the end of our services, would provide early memory loss classes, which brought in both the caregivers as well as the clients, and those were very, very successful, as I will discuss them further in the next few slides. Next slide, please. So these are the steps that were taken through care management. We would bring in the caregiver and the participant together to discuss our program, but also reassure the caregivers that by no means are we taking away their responsibilities, that we want to just be able to help them and provide them services that for the loved ones as well as for themselves. We also discuss potential care needs, connected them to primary health providers, weekly home visits, and we again, continued with our educational classes, and we had caregivers provide support. And this is a very big aspect of it, that we were able, because of through our mental health services, we're able to provide both therapy and counseling to our clients, both the caregivers as well as the clients, because if they were feeling had feelings of anxiety or depression, then we would have them see a therapist based on their needs. Next slide, please. We again, I point out the support and the education we gave to our caregivers through trainings, through therapy. We would provide them time off to be able to refer them to the Caregiver Resource Center of Orange County, which would provide them caregivers from their program so that the caregivers would be able to take some time off. Next slide, please. So our early memory loss classes were 3 sessions, and we would bring in the caregivers as a group together with their participants, with the loved ones, and we would have these wonderful discussions and conversations that everybody shared together. And it was very, very helpful for both the caregivers and the participants to share their feelings and their emotions and their frustrations and everything else that they were experiencing. Next slide, please. It's important to, again, overcome the stigma and challenges in minority communities, especially the Farsi-speaking communities, as well as the Hispanic community. And I reiterate this because OMID has had a long-lasting relationship with the community. We were really able to educate them on the stigma that is attached to mental health, and bringing them into the program was much easier than dealing with the Hispanic community because of the stigma that is attached in that community to mental health. Next slide, please. So we have had over 75 educational classes, over 200 MoCA screenings in all different languages, Farsi, Arabic, English, and Spanish. We have served over 50 people in our dementia and caregiver programs, and we are moving forward and hoping to reach higher numbers in that area. Next slide, please. If you are starting as an organization, we need to go through these steps of evaluating your existing programs. Think big and see where you can take your existing programs, reach out to your local Alzheimer's care organization and ask for different types of trainings. Also, make sure you train your case managers well and evaluate potential languages spoken in the community so that you can reach out to as many as possible. Next slide, please. The next steps, and I close with this, reach out to collaborative agencies to provide care, apply for a grant, and become a dementia care provider as part of our services and your services. We do have a sustainability plan that we hope to become a clinic and continue our services to the senior community, because I don't see this program going anywhere. There's such a high need for it, with the senior community growing rapidly within the next 10 years. And I believe it's our last slide. Next, please. And here's some contact information. Please feel free to reach out if you have any questions. Thank you so much. And I'm sorry I went over my time. I apologize.
No problem. Can we get to the last slide there? So as you enter your questions into the question and answer pod, you can take a minute to look at this last slide. There is currently an open funding opportunity for the program that Hala and Winnie's programs were funded under, the Alzheimer's Disease Programs Initiative. That announcement closes April 24th. There are instructions here on how to find that announcement. So we'll move into questions now. I want to start with Winnie. There's a question for you about your trainings, and if you could talk a little bit about the differences between the CADCT and CDP.
Okay, thank you so much for the question. So The CDP training and CAD-DCT training, the training protocol developed by the National Council on Certified Dementia. So if you wanted to learn more about the information, you can just go to their website, www.nccdp.org, and then you will see very detailed information about the differences between the programs. So elevator speech, CDP is kind of like a training to on basic on Alzheimer's and dementia, how to do the communication, how to take care of the clients living with Alzheimer's and dementia, and how to do the self-care. But then the CADDCP is a kind of like a train the trainer program. So that's why for council, we have selected 6 in-house staff to become the master trainer. So after they become the master trainer, they can utilize the materials and host the CDP training in-house in our staff members' most familiar language, and to train them on the standard training protocol and to assist them with the certification process. Hopefully my elevator speech answered a little bit.
Definitely. Thank you so much. So Hala, the next question came to you, but when Hala's done, you can definitely chime in. You talked about using terms instead of Alzheimer's disease or dementia due to stigma, and there were quite a few questions about this. Can you talk a little bit about what other words you may use, what language you may use, or do you not talk about it at all until a person expresses interest in learning more?
We really don't talk about it at all as much as we possibly can until the person shows interest. We always include ourselves into the conversation, saying we all are going to, sort of as we become older, we will start, losing our brain cells. We will start, the brain will start shrinking. So we have to take steps towards sort of living a more quality lifestyle. And so that we introduce everybody to the idea that just because you're putting your keys into the refrigerator instead of the cabinet, that doesn't mean you're experiencing early memory loss. So we sort of make light of the situation so that we don't scare them off, we don't intimidate them, and we sort of bring them in with the idea that we want to make sure that there are not alternative experiences that you are going through, such as depression or anxiety, and that's why you perhaps might have scored low, because they get very scared if you just say, hey, you scored below and you might have Alzheimer's. We don't want to go there with them. We say that let's take this further, let's investigate this and see why you're scoring low. It could be that you're not getting enough sleep, or your nutrition is not proper, or you just need to maybe go on a vacation. So let's discuss this further. How can we help you? And when you come back with them with those kinds of answers, it puts them at ease, because as soon as you use the word Alzheimer, they get scared and intimidated.
Great, thank you for that response. Winnie, do you have anything to add about how you approach the stigma around dementia and Alzheimer's with your work?
Yes. So at the beginning, we because we offer the education piece to our internal staff and also to our committee members in their most familiar language, Chinese. So at the beginning, we utilize the language again in Chinese, kind of like most popular in the mainland China, can use that words to describe Alzheimer's program. But then we didn't really obtain a lot kind of like a lot of feedback from the communities, or maybe because it's still to the pandemic. And then later we learned from Taiwan, we learned from Hong Kong, there is an alternative term how to describe Alzheimer's dementia in Chinese. And then we started to utilize another term. And then we have more kind of like outreach or feedback from the committee members. Hey, I wanted to learn more. I think sometimes Alzheimer's dementia is a very technical term in English, right? But then when it's translated into other languages, especially Chinese, there are so many different kind of versions. So my learning experiences, we have to pick a less stigmatized one when we wanted to do the translation. Again, I'm only Chinese speaking. I think it actually applies to all other languages.
Great, thank you so much. So another question that came up that both of you can speak to, have you ever done brainstorming to connect with the community or surveyed the community to determine what needs or concerns they have? And if so, how did you approach that?
Because we have our early intervention program with the seniors, we have always had part of that program a survey of asking them about their needs, services they need, therapy needs, brain health needs. So we've always known our senior community very well because of that experience, and also making sure we connect with them one-on-one and even inquiring further. Sometimes they need legal help, sometimes they need, so sort of making them understand that this is not just about, memory loss. This is also about other services that you don't have that are concerning you, that can cause anxiety. And so therefore, we want to make sure that, you're taking care of your needs, and this will relax you. And so therefore, so sort of bringing it all together under one package.
Great, thank you. Winnie, anything to add?
Yeah, so for this grant project, we focus a lot on our internal clients, existing clients through the HCBS stream, the Common Community-Based Services stream, including adult day services and in-home services, because we already provide services to them, and because we have to do all sort of assessment, plan of care every 6 months. So, during the conversation, we kind of like understand what needs they have, and also what knowledge level that they have in terms of Alzheimer's and dementia. So we didn't really do a formal kind of like assessment because we already know our existing 800 clients from the from our internal HCBS stream. A little bit different from other organization who may kind of like offering or partnering with other organizations to do the screening and services.
Great, thank you so much.
Can I just add on to that? We also do the GAT7, the PHQ-9 screenings with our clients. That also is very helpful to see where they stand as far as their, mental health and what needs they have and so on. So those measurements really work well as well.
Great, thank you. Oh, we have time for one more question. Hala, there was a question that came in asking, when OMID sends a letter to a primary care physician, if a person scores 26 or lower on the MoCA, do you follow up then with the primary care physician to see if the person was subsequently diagnosed and figure out what kinds of services you may direct them to? Are they directed back to you?
So here's the case, and I'll make it very brief. When the client goes to their doctor and says, I want to get tested for early memory loss, or I'm feeling that I'm, losing my memory, usually they're dismissed, usually. It's part of your age, don't worry about it. But when we do the MoCA and then we send the letter along with the MoCA score, the primary doctors now are given a lot more attention to their patients. So they take it a step further, and either they do further testing, MRI scan or CT scan of the brain, or they refer them to a neurologist. And so therefore we follow up with the primary healthcare and say, we're just following up on our patient. We want to make sure that, they're being referred to the right provider or specialists for further testing and so on. Is part of our case management, for sure.
That's great. Thank you so much. Well, we have reached the end of our hour together. I want to thank everyone who came on today to participate, and a special thanks to Helenia and Winnie Lamb for your excellent presentations. You can tell by all these icons that are floating across the screen that people are very happy to be here. So it's great to see that. So thank you everyone again for joining us for the National Alzheimer's and Dementia Resource Center webinar series. Our next webinar is called It's More Than Just Money, Strategies for Sustaining Dementia Programs. We'll have that webinar on April 25th, 2023 from 2 to 3 p.m. Eastern. Please keep an eye out in your email for registration information that will come to you from NADRC-webinars@rti.org. You can also reach out to us at that email address if you need more information. We hope to see you there, and thank you everyone again for being here today. Have a great afternoon.
Thank you.
Thank you. Bye-bye.